Okay, Elise, go ahead.
Thank you for attending our webinar on HPV disparities across specific populations, and we will be recording the webinar today. In addition, we will be sharing the recording link and the presentations after the webinar. This webinar series was organized by the Illinois Cancer Partnership Prevention Subcommittee. The host for today's session is the chair of the Prevention Subcommittee, Sarah Chavez. Our moderator for today's session is also the co-chair of the Prevention Subcommittee, Eric Adjei. And now I will turn it over to Sarah.
Thank you, Elise and Linda, and thank you to everybody attending today. We're really excited to have our group of speakers assemble today who will help speak to HPV disparities across specific populations. Just some housekeeping, we will be recording the webinar so that we can share the recording with you afterwards. And then you will also have access to the first webinar, which was also recorded. So in case you missed that first webinar or wanted to go back and listen to it again, we will be sharing those links. As our speakers are talking, feel free to add any questions or comments in the chat. We'll be keeping track of that during the talks, and we will have some time built into the end to allow for questions. And on that note, I would like to introduce our first speaker today. Dr. Milky Vu is a assistant professor in the Department of Preventative Medicine at the Feinberg School of Medicine at Northwestern University. And she will be speaking to HPV vaccination rates in Asian Americans. So I will turn it over to Dr. Vu.
Thank you so much, Sarah, for the introduction. Okay, can you all see my presentation?
Yes, looks good.
Okay, great. My name is Milky Vu, and I am an assistant professor at the Feinberg School of Medicine, Northwestern University. My research leverage community engagement and implementation science in order to promote health and well-being for minoritized and underserved populations, and focusing in particular on cancer prevention among Asian Americans. I have no conflict of interest to disclose. So the focus of my presentation today is on HPV vaccination among Asian Americans. And at around 22 million, Asian Americans are the fastest growing racial or ethnic group in the US today. They are extremely heterogeneous and comprise of people from over 30 states or countries, speaking over 100 different languages and dialects. And different Asian origin groups have diverse immigration history, cultural backgrounds, religious beliefs, and patterns of health service utilization. And I've done research on Asian American health for over a decade now. And one of the things that I found to be pretty challenging in my work is what we often call the model minority myth. And in a nutshell, this is a pervasive idea in certain corners that Asian Americans are a monolithic entity. They are all the same no matter which origin groups, and Asian Americans are all experiencing socioeconomic success and little disadvantage or health disparities created by structural racism. And now these are myths, and they don't reflect the reality or the diversity of experiences of different Asian origin groups. And unfortunately, one of the direct consequences of the model minority myth is that this leads to critical data gaps in the reporting of health outcomes for Asian Americans. And too often, different Asian origin groups are combined under one single category, and data are not reported separately for different origin groups. So I want to give an example that reflects some of the heterogeneity among Asian Americans that is relevant to our conversation about HPV vaccination. So this table is from a paper that reports cancer incident rates for the 6 largest Asian origin groups in the US: Chinese, Filipino, Japanese, Korean, South Asian, and Vietnamese. And what you see here is that if you're looking at the cervical cancer rate for Asian as a whole, then it's 6.5 over 100,000 person years, which is lower than that of non-Hispanic white at 7.5. But however, if you look at the rates for specific origin groups, then you actually see a pretty wide range. So for example, South Asian at 4.6, Filipino at 6.3, and Vietnamese Americans actually have higher rates than non-Hispanic white at 7.7. So this shows the need to have disaggregated data by origin group as opposed to lumping all Asian origin groups into one category. So many of us working in the HPV vaccination research field are familiar with the NIS team conduct annually by the CDC. And I want to acknowledge that the NIS team data are really useful in many ways. I've analyzed them and used them in my publications. But unfortunately, one of the things that NIS team does not do is providing public use data or reporting by Asian origin group. So they do collect data on origins of respondents. So they do include question on whether you identify as one of the Asian origin group, Vietnamese, Chinese, Korean, etc. But they do not provide this information in their public use data or reporting of the survey results. So for researchers like me who are interested in getting disaggregated data, unfortunately, what we get is just data for non-Hispanic Asian adolescents as a whole. And this is somewhat informative, but much of it is still very much a black box. So with the prior example, I've shown that there are heterogeneity in rates of HPV-related cancer, and that lumping all Asian origin group together is not helpful for understanding between group differences. And instead, what we really need is data disaggregation in order to identify the populations facing highest risk of HPV vaccine underutilization. And now I'd like to highlight some of the recent work in this area that do use national representative surveys and report disaggregated data. So this is a paper by Wang and colleagues that came out very recently, and the paper used data from the National Health Interview Survey from 2015 to 2018 and reports on HPV vaccination data for adults, and specifically comparing Chinese, Filipino, Asian Indian adults to non-Hispanic white adults. And what they found was that overall there is variation in HPV vaccination rates across Asian origin groups, and with Asian Indian adults having the lowest HPV vaccination rate at 23.2%, which is significantly lower than that of non-Hispanic whites at 35.6%. And the researchers further analyzed data by both origin group and nativity, which means whether the respondents was born inside the US or outside the US. And they found that the lowest rates of HPV vaccination were observed among foreign-born Asian Indian adults at 12.7% and foreign-born Chinese adults at 25.3%. And again, both significantly lower than that of non-Hispanic white counterparts. And this is actually one of our papers that are currently under review. And in this paper, we use data from the Health Information National Trend Survey, or HINS, collected by the National Cancer Institute. Now, this national survey asks several questions about whether respondents have heard about HPV or the HPV vaccine, and whether they knew that HPV caused several types of cancers. And for this paper, we use non-Hispanic white adults as the reference group and compare knowledge and awareness of these different questions of Asian Indian, Vietnamese, Chinese, Japanese, Filipino, and Korean adults. So as you can see here, again, there is between group variation for Asian Americans, and the adults from most Asian origin groups have significantly lower awareness of HPV or the HPV vaccine compared to non-Hispanic white adults. And when you look specifically at different questions about whether respondents knew that HPV causes cervical, anal, oral, or penile cancers, again, you see two things. One is that there is a good amount of heterogeneity for Asian origin groups in their knowledge of HPV. And the second important finding is that for each knowledge question, there are at least 2 Asian origin groups that had significantly lower knowledge compared to non-Hispanic white adults. And in particular, for 5 out of the 6 questions, Vietnamese and Chinese respondents had significantly lower knowledge compared to white respondents. And for most questions, Vietnamese was the group out of all Asian origin groups with the lowest proportions of respondent reporting knowledge or awareness. So having established these needs for disaggregated data to identify origin groups at highest risk, now I want to just briefly talk a little bit about another study that I did on facilitators of and barriers to HPV vaccination in Asian American communities. So when I first started out doing research in this field, there was just a lot of unknown. And so what I really wanted to do was to conduct a systematic review of all literature that exists on this topic and ask what are the different determinants of HPV vaccination among Asian Americans. Now, this work was done in late 2019, so about 3 years ago. And we did a search of PubMed and several different databases. And we found a total of 26 studies that have examined determinants of HPV vaccination among Asian Americans. And the origin groups that were most commonly studied were Koreans, Chinese, and Cambodians. And a few other studies focus on South Asians, Vietnamese, Hmong, Filipino, and Japanese populations. About half of the studies capture the perspectives of caregivers or parents on adolescent HPV vaccination. And several studies also focus on college students or general adult populations. And there is a wide range in the reported HPV vaccine initiation and completion across studies, with initiation ranging from 14 to 67% and completion ranging from 9 to 63%. So what we found is that a few studies capture the impact of health system or practice level determinants on HPV vaccination among Asian Americans. The studies that do look at the availability of language service at the clinic or insurance policy. At the provider level, most of the studies focus on the absence or presence of recommendation from providers about HPV vaccine. And these are some of the most common individual or patient level determinants across the 26 studies. And the most common ones include HPV vaccine knowledge or awareness, perceived safety of the vaccine, perceived susceptibility to HPV, beliefs about the link between HPV vaccination and sexual activity, perceived effectiveness of the vaccine, perceived cost, motivation to get protection from HPV-related disease, influence from family members such as mother, and English proficiency of the respondents was also documented in 3 studies as being associated with HPV vaccine intention and uptake. Happy to provide a copy of the paper to anyone interested. What I hope to do with it is to provide a comprehensive review of determinants that can be used in designing interventions to address HPV vaccination among Asian Americans. So for the last part of the presentation, and knowing that there exist these disparities in HPV-related cancers and HPV vaccination, as well as knowing some of the determinants of HPV vaccination in these populations, I want to shift to discussing some of the current developments in strategies to increase HPV vaccination for Asian Americans. Now, there are a lot of best practice that have been developed centering around health clinics. What can health clinics or health systems do to boost HPV vaccination? And these practices are really important because ultimately much of HPV vaccination is still happening inside the clinic or health systems. And what I want to emphasize is also a complementary approach in addition to these clinic-based best practice. So what can we do in community outreach to help individuals become more aware of the vaccine, know more about it, and increase community demand for it? And here's one of the rationale for why we should do community outreach on top of clinic-based practice. This is based on some of the formative work that I have done with Vietnamese Americans and their perceptions of the HPV vaccine. So if you recall some of the previous research that I present, Vietnamese is a group that is at high risk for cervical cancer, and they also have low knowledge and awareness of HPV when compared to other Asian origin groups or non-Hispanic white. So in my interviews with Vietnamese mothers who had an adolescent eligible for the HPV vaccine, some mothers talk about how they did not agree to the HPV vaccine right away when the providers recommend it. So for example, here a mother said, I made the decision a few months later. It was partly because I need to think and partly because I was busy and I could not make the appointment with the doctor. That's why my oldest child got vaccinated when she was 16. Another person said, when the doctor recommended the HPV vaccine for the first time, I did not let my son get the vaccine right away. I told the doctor that I would learn more about the vaccine. And the following year, I let my son get the vaccine. So these realities really point to the need for culturally relevant health education around HPV vaccination that parents or caregivers and others can assess prior to the clinic visit, because there might be barriers that exist to digesting or understanding materials when present during the brief encounters with providers. So these are some of the recent research that are developing solutions leveraging digital health for community outreach. It's very encouraging and interesting to see the work being done in this space. So as you can see here, this is a study that has built a storytelling intervention in a mobile web-based platform for Korean American college students. Another one is the group chat function facilitated by a lay health worker to encourage family discussions around HPV vaccination and cancer screenings for Vietnamese families. And the third develops a narrative intervention targeting HPV vaccine behaviors among Khmer mothers and daughters. Most of those, I must say, are pilot studies with small samples, but they do have positive preliminary outcomes and show some potential. I also want to briefly touch on my current work addressing HPV vaccination among Asian Americans in Chicago. And I am currently working with partner organizations in Uptown, which is an area in Chicago with high concentration of Asian residents, especially those who are foreign-born. And we actually were just awarded a small grant to co-design culturally relevant strategies with community partners. And the plan is to leverage existing programs and community resources, and also identifying HPV vaccine champions in the community that can help us increase community demand for vaccination. So we just got the grant, so the work is very much at the preliminary stage, but if you're interested in learning more, please get in contact and I'm happy to share some of the ideas of where we're going. So I want to end with some recommendations for research, practice, and policy to increase HPV vaccination among Asian Americans. Now, going back to what we discussed earlier with the data gaps, public health surveillance systems really should collect and report disaggregated data for different origin groups. And there's some movement at the federal level in recent years, especially to acknowledge the diversity of Asian Americans and support disaggregation of data. The Biden and Harris administration established the White House Initiative on Asian Americans, Native Hawaiians, and Pacific Islanders, and they have developed national strategies focused on expanding the collection and use of disaggregated data at the federal, state, and local level. And they also focus on strategies for improving health outcomes and eliminating disparities for these populations. And in addition to improvements in the collection and reporting of data by public health systems, I think that with health providers and health systems, there is a need to understand the heterogeneity in HPV vaccination knowledge and uptake in Asian American communities across different origin groups. They should also take into account how cultural beliefs and contexts, immigration status, nativity, English language proficiency, and other sociocultural factors might influence vaccine confidence, intention, and uptake. And then finally, going back to the point earlier about community outreach, and again, thinking about the diversity of this population, this is a place where the model of one size fits all interventions might have limit utility. And instead, what we really want is partnerships with trust community agencies and messengers, including CBOs and social services, to deliver culturally tailored, linguistic appropriate interventions that leverage digital health technologies whenever appropriate so that we can ensure that we can reach a large number of people. I want to acknowledge my community partners and funders that have support the research present in this study. And please please get in contact if you're interested or want to learn more. Always happy to talk. Thank you.
Thank you so much. I know that issue of disaggregation of data has come up over and over again in many conversations that I've been involved in. So thank you very much for pointing that out and for all of the really specific information. I think that's going to be what we really need to be effective, and especially as a community outreach person myself. Okay, so our next speaker is Dr. Nita Karnik-Lee. She is an associate professor in the Department of Obstetrics and Gynecology and the Office of Community Engagement and Cancer Health Equity at the University of Chicago Comprehensive Cancer Center. And she will be speaking to HPV vaccination rates among urban, rural, youth, LGBTQ, and childhood adolescent cancer survivors. So Dr. Lee, thank you.
Thank you. I'm going to share screen. I am hoping that you can see this. Okay, excellent. It's always nerve-wracking, no matter how many years we're doing this. Okay, I'm Nita Lee. I'm a GYN oncologist, and so I wear two hats, both as a clinician, but then as the assistant director for and faculty lead for our Office of Community Engagement and Cancer Health Equity. HPV is a critically important topic for all of us, obviously here today, and I end up seeing a lot of the downstream complications of this, and so HPV vaccine as primary prevention is particularly important to me. I have no disclosures. When we think about HPV primary prevention cancer, we have sort of a significant amount of tremendous opportunity as well as vulnerability. It's limited by stigma of HPV-related diseases and cancers, and this is the underlying problem that I think all of us who do HPV-related work need to we all understand this, and we know that that's a unique barrier to HPV vaccination compared to other barriers. And this stigma and this can also be amplified in some of the communities and some of the populations that I'm going to talk about today. We know about misinformation, vaccine confidence ebb and flow, as well as the fear of diminished vaccine uptake, but then hopefully maybe activation of the public health systems that we know we are using due to COVID as well. When I think about vaccine uptake in special populations, I think about these themes as what I'm going to talk about in this very brief talk today. What does the data tell us? What do we not know, right? So we do know that HPV vaccine is underutilized in special populations, and that specific groups, ironically, are underutilizing HPV vaccine, but may have higher risk for HPV-related diseases and cancer. And then, when we think about this triad of the stigma, the miseducation, or the gaps in education, as well as the access, that's where we can think about the things that we all think about for just general HPV vaccine uptake. How can this be unfortunately exaggerated in special populations? I think when we're thinking about the groups in mind, we all, as people who work in public health or community outreach, have to think about what have we learned in special populations and can use from other health campaigns that may not be HPV specific, but that target the special population. So I'd like to have everybody keep that in mind. And then as we're thinking about this, who are the key sort of non-traditional partners that may be unique to serve these special populations? And that may be a point of discussion for us. So just as a review, this group knows this already. Males and females, 9 to 45, prevention of multiple cancers and precancerous conditions. You can see, even when we think about the current FDA approvals, how this can be somewhat sort of limiting when we're thinking about LGBTQ and kind of different gender identities as well. So I think this is really important to think about just our verbiage as well. Age 27 to 45 is recommendations for shared decision making. And I think this is particularly important in the populations that we're going to talk about today, because many of these groups and individuals may have been missed in the traditional age categorization for getting the childhood vaccinations, young adult vaccinations up until age 26. And so this is really an important group to think about, that is like, how are we going to kind of catch up in these special populations? When we look at the Illinois data, we look at kind of like, Illinois 5-year mortality rates are increasing in oropharyngeal cancer. And so that's really important. There's ironically decreasing in cervical cancer here, but I will say that there are higher risks overall and higher incidence of late stage cervical cancer showing up throughout the country, particularly in Black women, and higher rates of increasing rates in Hispanic women of cervical cancer in general. So when we look at like our first differences in terms of differences in geography that we can see in terms of like where are the cancers happening, and then we can think about like where are the HPV vaccines happening. So we know that when we think about rural cancer incidence, we actually see that HPV related cancer seems to be burdening our urban rural communities more in terms of higher rates of new oropharyngeal and cervical cancers. And that's really important to kind of think about in terms of like, where is the gap of the HPV vaccine to the cancers found even going to be more striking, and may be like the source for where we want to kind of intervene most closely. When we think about the age adjusted, this is again female versus male, and showing you the discrepancy as well as the wide range of types of cancers that we need to be thinking about. And again, this is in terms of new associated cervical cancers, but I think again, we don't want to exclude the discussion of disparities when we're thinking about urban and rural as well, whereas sometimes like certain classifications tend to be, thinking about rural as only rural white. And I think it's really important to kind of think about like all of our populations across this, how some of these populations will be doubly influenced by not only differences amongst their geography, but differences amongst their race, ethnicity, immigration status, or socioeconomic status. I'm not going to go through too many of these things, but we can kind of see that up-to-date vaccination falls, the Illinois sort of falls in the midst of this range in terms of 61 to 68%, but we know that this differs as we get into more subpopulations. When we look at like who are estimated vaccine coverage amongst adolescents in the US, we see these differences that we can take into consideration as well when we're thinking about these populations. Illinois specific data, again, that really demonstrates that we are getting better at up-to-date vaccination rates, but that this also differs greatly by insurance status as well. When we think about vaccine uptake in rural areas, we think about up-to-date vaccination and initiation of vaccine coverage also being lower compared to urban communities, and on average about 10% lower in comparison. And that's kind of some accumulated data from the CDC as well. We know that there are multiple factors that can exist for barriers that may be specific to rural populations, including access to travel, work-related constraints, transportation costs, as well as this idea of like declining provider availability. So this idea of overburdened providers. Are the PCPs in rural areas potentially more responsible for too many more things than in urban areas as well? And lack of provider recommendation is a consistent area that we know it affects HPV vaccine uptake. We have this idea of knowledge gaps and misinformation campaigns. Are we seeing more of these in rural areas? Are we seeing more campaigns that actually are targeting like digital media, social media? And that actually is an interesting area of research as well. There have been some data on looking at like belief systems such as fatalism or kind of like approaches in rural communities. And these, I think, we want to make sure that we don't stereotype rural communities. So some of these have to be taken with the fact that they may be just the context of the community studied. But there is kind of this general sense of like, is there more of a distrust of the medical system, vaccines, and does this become something that's a part of a political identity, which can actually really help, contribute to this sort of gap in like what happens at the provider patient or the parent provider patient intervention. And then the idea of like our rural community do we have more competing priorities or different competing priorities? When we look at like HPV vaccine coverage amongst US teens across this continuum, we do know that rural girls complete the HPV vaccine less often than urban girls, and poverty can be a mediator of that. But when you link for poverty or when you account for poverty, it does not necessarily show up as the same. Girls throughout, whether or not were categorized as poor or not poor, still had lower uptake. Rural boys continue to have lower odds of both vaccine completion and initiation, even despite multivariate analysis. We have our own moderator here has presented some really interesting data, and I'd look forward to the discussion in terms of like looking at Central Illinois. And this really speaks to kind of what Dr. Wu spoke about, is that do we get disaggregated data, and where is our data coming from? Like we don't have a lot of data from specific rural locations. For example, here, this paper was really important because it comments on the fact that we have Illinois data, we have a lot of Chicago data, but we don't know what's happening in the center of the state. And this looked at HPV vaccine initiation and completion and showed that overall HPV initiation was 46.2% and completion was 24.7%, which is much lower than national and Chicago land area. And if in the rural populations, there were 38% less likely to initiate and 24 plus less likely to complete the series. And this was also worse if they had not completed other childhood vaccines. And so this kind of, again, associates like, how are we doing with like other vaccinations at the rural level, and like what can kind of be related to the HPV in particular. I will say I wanted to kind of cover this. This is an excellent paper and review by Dr. Brandt and colleagues looking at a summary of policy opportunities specifically for HPV in rural areas. And I think this was big P, little p. So like what can you do at a systems level or at a hospital or provider level, and what do you need to have like policy initiated for? And so going through this, like healthcare provider communication and recommendation really remains one of the strongest indicators and the strongest ways that we can improve this. We can think about reminder and recall systems. A lot of this, again, also has to do with like the data and like where we're getting data. And this is something that I think will be interesting to discuss as well. Standing orders. So this is something that we're just starting to do last year, is in terms of not necessarily needing a physician's order, but allowing clinic MAs and other staff to be able to like make sure that patients are up to date. Thinking about, how we're giving the providers feedback. All of these things can be equally, we always think of them as in any provider community, but I think in thinking of like rural providers, this may be particularly helpful. I think one of the things that's really important is the use of pharmacies in rural communities, because this may be another way that if we are able to get, which Illinois we're allowed to do, providing HPV vaccines, this may actually be a really big way to increase the providers that will be able to give the vaccine. Finally, we think about school age entries and communication campaigns that may be really important to kind of think about, like, are we doing enough communication campaigns that are through trusted messengers in rural areas? And that's another area that we can look at. When we look at HPV vaccine and uptake in childhood and AYA cancers, we know that the population is at higher risk for secondary cancers that are HPV driven. Females may have an up to 40% higher risk of HPV driven cancers, and males may have a higher risk of 150% of HPV driven cancers. And this may be driven by higher risk behaviors, as well as potentially some immune responses to their prior treatments. What we know, though, is that these are also groups of individuals that are less likely to have received HPV vaccine. This, for example, shows that in those who are under age 18, 48% among males and 29% among females, rather, vice versa, 48% of females and 29% among males were the only people who have received this vaccine. This was worse when you looked at survivors who were greater than age 18. So this is, again, like a striking opportunity for where we need to be doing more work. We know that the opportunities could be that we can activate the oncologist and the PCP as part of survivorship care. So lack of recommendation by providers was 73% of the problem. Concern on insurance coverage for older individuals was also concern. There's a gap and an unsure, problem with like who is responsible. And this is work that we did in our own oncology center, looking at like respondents who feels like they should be responsible for this survivorship care. Should it be the primary care doctor? Should it be the oncologist? And it really was the idea that like direct guidance from oncologists to primary care physicians and to patients directly may be a potential strategy that we've missed. And then thinking about survivors as young adults, and again, emphasizing this idea of like catch-up vaccinations may be particularly important in terms of improving vaccine knowledge, vaccine recommendations, and the role of the oncologist, as well as using sort of these other digital and other methods for getting this messaging out. When we think about HPV vaccine uptake among LGBTQ communities, we also need to be thinking again about this triad of stigma, miseducation, and access. So we know that there are higher risk of HPV-driven cancers, particularly anal cancer and cervical cancer, and this can be between men who have sex with men, the lack of screening in anal cancer, and higher risks in HIV-positive gay or bisexual men. When we think of cervical cancer, for example, we think of bisexual or lesbian people getting less likely to be screened, trans patients being less likely to seek screening or even asked about cervix cancer, and then HIV as a cofactor. Cigarette smoking as another cofactor is a really important sort of global risk reduction effort in the LGBTQ communities as well. This is also an excellent review that really details kind of the different burden and HPV vaccine strategies here. When we think about HPV vaccine uptake among LGBTQ communities, we know that the vaccine rates are lower. One older study, which was done in 2015, showed that only 13% of gay or bisexual males had received the vaccine. And we know that HPV vaccine is acceptable to patients, but it is still less recommended. And that's, I think, one of the major barriers to this community as well. So when we think about opportunities, one of the biggest opportunities we have is probably this idea of like blanket promotion of HPV vaccine, because there are people who have not disclosed their gender status, or they've not disclosed their LGBTQ status, and so making sure that we're not just messaging this as a vaccine that's available and preferentially giving it or messaging it as, for example, how it was originally messaged with men who have sex with men, may decrease the stigma and make people feel more comfortable. Again, tailored messagings and intervention, improving trans health. So this idea that like it's really specific, not about like talking about male versus female, but really thinking about like organs at risk for this and the risk reduction. And then ensuring HPV vaccines are offered at sites of care that are both accessible and welcoming. And so that's really important in terms of the idea of like bundling HPV vaccine with something like HIV testing or PrEP offering. And so I think this is kind of gets at this idea of like, how do we blend these special populations that may have kind of like amplified risks of HPV, not cofactors, I guess, HPV risk factors for developing HPV-related disease, but also amplified risks of not getting their HPV vaccine as well. So when we look at sort of the Illinois Action Plan to eliminate vaccine preventable cancer themes, and we're thinking about improving access to the data, evidence-rich stories, and building trust and influence, and then these kind of triads in special populations, I think this becomes really important. So I'm going to end there, and thank you all very much, and look forward to questioning.
Thank you so much. I think a lot of these same themes about, it's not going to be a one size fits all approach. I think that's kind of the overarching theme that we're encountering with all of our speakers today. So our third and final speaker before we get to our discussion is Dr. Marielle Frachon, who is an assistant professor of pediatrics at Rush University's Children's Hospital, as well as the JHS Cook County Hospital, and the immunization program medical director at Chicago Department of Public Health, who will be speaking to HPV care gaps as well as catching up. So thank you.
Thank you. Can you hear me okay?
Yes.
Great. Just to revise the bio there a little bit, I was medical director at CDPH for 6 years, and I am no longer there. I'm at Rush University Children's Hospital. So I'm going to talk about HPV vaccination care gaps and catching up. Okay, so the post-pandemic urgency of catching up, of course, is on all of us, no matter what we do. We're catching up on our lives, social lives, we're catching up on a lot of things. Kids are catching up in school, and around the world, there's a large backlog of children around the world who are not up to date on vaccines. HPV is not unique in this. Measles vaccine, MMR, creates a big problem worldwide in terms of increasing vaccine preventable disease spread. But when we talk about HPV vaccine, that also means an increase in HPV related cancers some 10, 20 years down the line. And so it is urgent in a very different way than catching up on some of the other vaccines. And so the WHO gave some numbers that between 2019 and 2021, obviously when the pandemic was, coverage of the first dose of HPV vaccination fell by 25 to 15% worldwide. And that meant that 3.5 million more girls missed out on HPV vaccine in 2021 compared to 2019. And they have less data on boys, but we can assume a negative impact on community immunity. And the US has better uptake in boys than around the world. And so there's even more of a problem for oropharyngeal cancers in men around the world, and other cancers. So some of the proposed solutions by the World Health Organization, which may or may not work here, is that we optimize the HPV schedule to improve access to the vaccine, which I'll talk to you about what their proposed approach is, which is kind of exciting, and then decrease the burden of follow-up required to complete the series, which has always been a problem here for us, and strengthen HPV vaccination programs and expedite implementation, which in public health is always our challenge. And obviously having participated in the COVID vaccine response at the Chicago Department of Public Health when I was there, we have a lot of funding and lessons to learn from that response that can be applied to strengthening HPV vaccination programs. So the World Health Organization actually just on December 20th, so just a few weeks ago, decided to put out a position statement that was an update of an April 2022 position statement that recommends an alternative off-label single-dose schedule to provide comparable efficacy and durability of protection to a 2-dose regimen. And this is extremely exciting for those of us who have been following HPV vaccination, and for those of us who have been struggling very hard to get adolescents and adults, for those of us who treat adults, in for a 2 or 3 dose schedule. This is never easy. COVID, you know, we tried many different things with COVID, but the same challenges occur no matter what vaccine you're talking about. Completing a series of vaccine is a very different problem than initiating a series of vaccine. The initiation is about trust in your provider, is about access. Completion is completely about ease of access and proactiveness of some entity, whether it be public health or a primary care provider, to remind that individual and make it easy for them to schedule. So very different approaches depending on which dose we're talking about. And a lot of the data that the WHO used to make this decision was in studies that had post hoc data from studies in when they were doing 2 versus 3 doses. They did post hoc analyses that they were able to look at the responses of the patients to 1 dose. and see how long it lasted. But this Barnabas et al. Paper, which studied the efficacy of single dose among young African women, that was published in any New England Journal of Medicine Evidence recently, was also a big push for the WHO to put this in writing, that alternative off-label single-dose schedule is what is needed to catch up the world in HPV vaccine, which is a huge step. One of the other studies is this Costa Rica vaccine trial, where they looked at HPV-16 antibody. And if you remember, HPV-16 is sort of one of those that we look at. We have the most data on it because it was included in Cervarix, which was the first HPV vaccine, which was 2-valent, and then has been included in our 4-valent and now 9-valent vaccine. And so we use data sometimes just looking at the HPV-16 antibodies so that we can apply it likely to the lasting immunity to our other valent vaccines. And so this study, you can see the antibody titers for HPV-16 with 3 doses is obviously higher. That's the line in purple. 2 doses, it tracks along pretty well. It's very similar. That reached non-inferiority criteria. At 1 dose, you're still getting pretty good titers. And what's really amazing to see is that, you know, on the x-axis, you have years after vaccination. 11 years after vaccination, you have this steady antibody response. So steady, just with 1 dose of vaccine. And the levels are at least 10-fold above those that are unvaccinated, which is the black line at the very bottom. So that in and of itself is very encouraging to me, that even if we have patients here in the US who we are struggling to get them to complete their series, we've given them long-lasting protection against this cancer-causing virus. And I wonder about what we'll do in the US with this data moving forward. So just to remind everyone, the current US REX is what the WHO recommended in 2017, which is that you get a 2-dose schedule if you're 9 to 14, 3 doses if you're 15 to 20, and 3 doses if you're immunocompromised or have other risk factors like living with HIV or have a history of sexual abuse. But the 2022 SAGE recommendations, and SAGE is the strategic advisory group of experts on immunization, which is like the advisory committee on immunization practices for the world. So it's like the CDC group that advises on the vaccine schedule, but for the entire world. And so their recommendations are now that you can have either a 1 or a 2-dose schedule for those that are 9 to 20 years old. And that if you're over 21, you can use a 2-dose schedule. And so the only populations that need a 3-dose schedule ideally is our at-risk populations like immunocompromised, living with HIV, and history of sexual abuse. And so the current US RECs are the old WHO RECs, and so there's no change in the US recommendations. I just wanted to show some of the data and what's new out there and what might be coming down the pipe if the US follows suit. They don't currently have an ACIP advisory group committed to this topic, unfortunately, but they are reviewing them at their meetings. They're reviewing the data, and so I hope that they will form a group to look at this further, because I think the early data looks very promising, and I'd like to see the data with the 9-valent vaccines as well. And so this slide comes from Lori Markowitz's slide from the June 2022 ACIP meeting. And so just to get into more about care gaps and the impact of policy on even country level policy on vaccination rates, depending on what country you're in, you have a different level of recommendation versus requirement when it comes to vaccines. And this is an example in Japan that they ended their proactive HPV vaccination recommendation. And you can see in the red line how their coverage plummeted. The blue bars are the proportion of women eligible for catch-up vaccination. Okay, that's not how many are vaccinated. The pink lines are the pink bars are the ones that have been vaccinated. And so if you don't have proactive policies in your country and you don't have money put towards funding national catch-up programs, your vaccine coverage rates will plummet. And we have a slightly different situation here in the US, which is good because we have a program called the Vaccines for Children's program, which has never stopped providing free HPV vaccine to physicians in the program for those who serve Medicaid and uninsured and underinsured children. And they've never stopped recommending it proactively since they started in 2006. So when you think about how COVID-19 affected our coverage in the US, you can see here that the coverage was actually higher at younger ages for pandemic years, which was extremely interesting to me. And this is from the National Immunization Survey data that you've been seeing data from when the previous two presenters. And so they are the birth cohorts, 2006 to 2008, but they were vaccinated during the pandemic, and they were younger than in years before the pandemic. And I think that that's a very good sign. That's a trend that in the US, we actually are being proactive enough on the whole. You know, as we've talked about, there are absolutely disparities among different populations. I want to show this because you can see, we talk about how good our coverage is in the US, but Tdap and meningococcal vaccine are still way higher, you know, upper 80s, lower 90s in terms of coverage in the US compared to HPV vaccination initiation in females and males, and then being up to date on those vaccines. So that's important to know. And then as you've seen from the other presenters, there's disparities by insurance coverage. There's disparities by whether you're below or living above the poverty level. What's interesting, though, is that when you're below the poverty level, you actually have higher coverage. And we believe that that's due to the presence and the existence of the Vaccines for Children's program, which provides free vaccine to the providers that see individuals below the poverty level who are more likely to be on public aid or a managed care Medicaid plan. We need more disaggregated data. Obviously, you've seen this slide many times, but we do have white non-Hispanic adolescents are less likely to be vaccinated than other races. And previous presenters, we talked about that in detail. I'm gonna go through this and get to sort of the meat of the presentation, which what are the differences in care gaps, resources, and attitudes at the community level. And I'll go quickly through here the fact that there's data on the Chicago Health Atlas for cervical cancer screening rates by community area, cervical cancer diagnosis rates by community area, and then mortality rates for cervical cancer by community area. And what we need is vaccination rates by community area so that we can really target messaging, get trusted leaders, immunization ambassadors in each community, doing what each community says they need in order to promote HPV vaccination. I'm going to talk about a few lessons from some past projects, which we've talked a little bit about already, but we published this in 2013 to 15 from a CDC funded project at the health department. And we learned a lot of things, but one of them is that vaccine champions are extremely important and they need to be in every healthcare setting, and they need to be in the community. So they can be parents, peers, healthcare providers, medical assistants make a big difference in terms of being vaccine champions. And then the confidence of the recommendation is the most important thing that we can do as providers. And then also just individuals in the community to give positive messages around the cancer prevention power of this vaccine. We're going to continue to integrate eye care registry into primary care to direct closure of some of these care gaps. And you do that by using the reminder recall reports that exist and some of the improved text technologies, which help to bring patients back in, and sometimes to non-traditional immunization spaces, like potentially a caravan showing up at the Mexican consulate, for example, which we do, which the health department does, excuse me, in order to vaccinate, just be more accessible for people. And then VFC providers in the community, obviously PCPs being confident and giving confident recommendations, presumptive recommendations, is the most effective way. But if you don't have that ability, there are standing clinics that public health has, and these are two examples. Pharmacies, like our previous presenter talked about, are really important because they fill care gaps in the community, and there are always community events, especially around back to school, where we need to encourage people to also bring HPV vaccine, because it's not required for school, but it is recommended for school. And we just want to, younger generations are ready to take charge of their health. The COVID pandemic has taught them how to do this. And so we need to be there to help them take care of their health and help them be autonomous. Yeah, and I'd love to share some of this other stuff, but I know that we're out of time, and happy to answer any questions.
Thank you so much. So I will pass it over to Eric for any questions or addressing any of the comments that we've had in the chat.
Yeah, so thank you very much for the presentation. Mona had one question which Sarah and I answered, but I wanted to just read it out. So she wanted to know if the data aggregation issue exists among Middle Eastern populations, and we said yes. And so I was actually going to follow that up with it seems like the theme for all three presentations is that there's issue with data. Either there's no data in rural areas, and even if there is data, it's aggregated at a higher level. So how can we all fix this issue as researchers, community people, the healthcare population? How can we do this?
I think the other speakers might want to answer this as well, but I do want to point out that the federal government is really limited in the categories they have when they collect data, and that has so many downstream effects, and it really prevents clinicians and researchers from asking important questions and answering important questions. And so until we get better federal categories, which we rely on the American Community Survey based off of each 10-year census to do a lot of analysis. Until we have better categories there, the local public health departments will not be able to disaggregate.
I agree that I think, like data inequity or sort of the erasure of these different categories is not a problem, that is only with Asian Americans. It happens to, the MENA category, with Arab Americans being lumped into either the white population or Asian Americans, happen to, like in a lot of the data that we get with HPV vaccination, we don't get data specific for American Indians or Alaskan Natives. So, these issues are very much present, and challenging. I would say one thing in terms of, thinking about national or nationally representative surveys or public health surveillance system at the national level. I think one of the big challenge. So I talk a little about collecting and disaggregating data, but in order to collect data, you also have to make it accessible in different language, right? Like a lot of our surveys right now, like the NIS teen, for example, is only available in English and Spanish. And so, by virtue of that, we're leaving out a lot of, and our country is very diverse. The US is very diverse, have a large number of foreign-born populations that speak different language. So I feel like a lot of the planning, even at the national level, have to incorporate this, the reality of the diversity of our populations, and think about ways in which we can bring more people in from like the beginning, the collecting data stage.
I want to highlight that as being just shockingly important. And I also want to remind people that the National Immunization Survey, Illinois' rates are based off of 434 interviews last year, and Chicago's were based off of 100 and something. And if they're only being delivered in English and Spanish, what are we really learning about our rates anywhere in the country? And I think that advocacy towards CDC approaching this exact topic is absolutely needed. And it would be helpful if anybody has a way of getting to them and offering topics for their next ACIP meeting. I think that it really blows up all the data they have about all vaccines.
I totally agree. When you look at where the numbers are that we base a lot of our interventions on, and our it is just, it's always really shocking, I think.
Yes, yes. And I know the paper I wrote, I even contacted CDC because luckily I know someone that worked there, and I said, if you look on, it says Chicago and the rest of the state. I'm like, well, what do you mean by the rest of the state? And they say, oh, it's actually based on an estimate. So we all need to do better. So we are at almost 2:02 now. So, and I'm going to close this so that respect everyone's time. But we would like to thank the panelists for taking time to talk to us. And I think there is an evaluation that will pop up after we close. Please fill those up. It will take about a minute or so to do so we can use that for our future educational programs. So thank you very much.
Yes, thank you so much to all of our speakers today.
Thank you. Bye-bye.
Bye.